Welcome to the Staying Active podcast, brought to you by Active Health, Connecticut's premier preventive health center.
Welcome to Staying Active with Derek and Dr. Jon. Very cool. Officially recording, so our first podcast going here. I figured we could just jump right in with a little bit about you, Jon, and we can kind of go from there. Talk about why we're doing this for a few minutes, and then we can jump into our first topic.
Sure. So, uh, I am Jon Lis. I'm a primary care physician at Active Health. Been practicing independently since 2021. Did my training all in the state of Connecticut. So UConn for med school and Yale for residency. But really interested to do this, and something like this has been kind of on my radar for a long time because there's a lot of information out there. There are a lot of pseudo influencers giving questionable at best and harmful at worst advice. And that's something I have to answer and respond to on a clinical basis on an almost daily basis. And so having an outlet to provide some, real information, so to speak, I think is really useful. So I'm really glad for the opportunity to do this.
Yeah, I'm really glad you brought that point up because I think that will we're going to talk about that a lot in the coming weeks and months, I'm sure. The current environment for how people take in information and the sources that they are getting it from, I think is really, really important. Um, Probably a little bit about me really fast. I'm Derek Marsette. I am one of the co-owners of Active Health. Um, I work with pretty much everyone in the organization, obviously with you, Jon. Mostly on information dissemination and making sure that we're giving out quality sources of information in a way that's digestible and appropriate for the masses. Specifically, I'm a personal trainer, and I have been for almost 20 years. I have held or currently hold certifications in training, strength coaching, sports nutrition, supplementation science, corrective exercise, you name it, it's alphabet soup. Uh, None of which I think really matters, but I just try to find information that is the most appropriate for everyone and try to break it down in a way that's understandable. And I think that's where you and I have a an awesome crossroads. We both come from very different backgrounds. We working with the same company, and we have a desire to make sure people get information in the most appropriate ways. And I love the term snake oil, trying to avoid as much snake oil as possible, or at least give people the tools to identify when it is being fed to them or sold to them.
Absolutely. And that's tough. It's tough to identify, but snake oil is what we aim to avoid at all costs.
One can only hope that we will just take the strides necessary to do that. Um, so I had some stuff prepared for today, and I think that a million topics we could cover for episode one, but we might as well just pick one and jump right in. So we had been talking a lot recently about thyroid health, and thyroid health seems to be something that comes up constantly in primary care, not just in our practice, but just kind of generally. And from the personal training perspective, it's limited, what kind of information, one might go to me for on this topic. Um, but it does seem that people are confused in every area on this, and they often are a little bit anxious uh, about their thyroids, just kind of generally. So, before we jump into anything kind of pointed, can you think you could address why?
Uh, that's a good question. It's the thyroid is an interesting gland because it's it produces a hormone, thyroid hormone, and there's two types of active thyroid hormone. There's T4 and T3. And these two hormones do so much in the body. They're called endocrine hormones because they can go throughout the body and they can affect pretty much every organ system and function that we have. Things from, you mentioned anxiety, can actually, if you have too much thyroid hormone, can cause anxiety. Too little can cause symptoms similar to depression. Can adjust your temperature, your metabolism, your weight, your heart rate, your digestion, your absorption of nutrients. I mean, the list really goes on and on. And so, having a hormone that is um, so that affects so many different systems really makes it difficult because really any symptom that a patient has or anytime a patient is feeling unwell or out of balance for lack of a better term, people sometimes and often point to the thyroid as the culprit, and are curious like, oh, is this a symptom of high or low thyroid? And that's termed hyper or hypothyroidism. So it does so many things. So often it's implicated in everything.
So it's like, moderately important then.
Yes, and it's most people will be familiar because if you get any sort of blood work done, most primary care physicians are checking something called the TSH. And so just to maybe it'll be helpful to kind of just dive in a little bit to
Sure.
the just normal thyroid physiology. And so it all kind of starts in the brain. And so you've got an area of the brain called the hypothalamus. It's an area kind of right in the center of the brain, and that releases a hormone in response to various body signals, for lack of a better term, called TRH. And TRH then will go to your anterior pituitary gland, another gland in the brain, to tell it to release something called TSH. And TSH stands for thyroid stimulating hormone. And that's the thing that we're checking in the blood. That is the hormone that tells the thyroid gland to produce T4 and to a lesser extent T3. T4 is the main one it produces, but T3 is kind of the more active hormone in the body. Um, the thyroid gland, if you kind of look at your neck, people often know it's in the neck, but it's actually kind of low down. It's about where you'd wear a bow tie. So it's like lower down than your Adam's apple and certainly lower down than like under the chin area. And it's about the size of a small, a farfalle pasta, like those bow tie pastas.
There we
It's
go.
about the
Yeah.
size of that.
Now we're
That's right
talking.
here, and it's a similar shape too, to like a farfalle pasta. I think that's the right one. Maybe I'm getting my pastas mixed up, but the bow tie pasta, most people are familiar with. And so that is a kind of a centrally located gland. The thyroid gland, in response to TSH, will produce thyroid hormones. And the interesting thing to keep in mind is that there's an inverse relationship between TSH and thyroid function. As an example, if you have a very high TSH, that means you are low in thyroid function. That means you are hypothyroid. If you have very high TSH, that means you are very low TSH, rather. If you have very low TSH, that means you are high thyroid, hyperthyroid. And so that's just something to keep in mind as people look at their own lab results that they get from their primary care provider.
Interesting. So essentially what you're saying is there's a lot that could happen in both directions, right? In the hyper or the hypo, and essentially you're recommending there are certain panels that you would look at with when it comes to like blood work, things like that, that would tell you what's going on here.
Yes, exactly. The main panel that is ordered, kind of the gold standard, is called the TSH with reflex to T4. And what that means is you get the TSH checked. If the TSH is normal, and no, and in most assays that's between 0.5 to 5. If that's normal, then great. You are what we call euthyroid, meaning your thyroid is normal. There's potentially a little bit of nuance to that, but for all intents and purposes, your thyroid is normal. uh, Hypothyroidism or low thyroid function is much, 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 much more common than hyperthyroidism or high thyroid function. And typically we'll see that with a slightly high TSH. Um, Although the interesting thing is, as people live longer, their TSH, the normal range of TSH increases. And it's about 1 point for every decade of life you've lived. So Again, that normal range 0.5 to 5. If you're 70 years old, you can have a TSH of 7, zero point 0.5 to 7, and that's generally normal. If you're 100 years old, you can have a TSH that's up to 10, and that's generally normal, meaning we just don't treat it. We don't throw medications your way to treat just a number. Um, so that's kind of, and most people are familiar, or if you're going to get diagnosed with something, most people are getting diagnosed with hypothyroidism as opposed to hyper.
Hmm. Is there like a particular danger to ignoring some of these labs? Like, I guess maybe a better way to ask the question might be, you know, how do you determine whether or not you, as like a potential patient, might have a problem with your thyroid, and at what point should you like get looked at for something?
So that's a great question. Again, since the symptoms of thyroid dysfunction are so varied, um, making a diagnosis clinically of hyper or hypothyroidism is very difficult. It's very difficult for your physician to say, oh, just based on having a high heart rate, you're hyperthyroidism, or just based on the fact that you've gained some weight and you feel cold frequently, you've got hypothyroidism. The diagnosis is typically triggered by the lab readings, and that's one of the things that we use to guide us. So the TSH is the thing to look at. And so making sure that that's checked at least once a year in a kind of a standard blood panel for an annual physical is really important. If the TSH is abnormal or symptoms are persistent despite ruling out other causes of things like, fast heart rate and weight gain and feeling cold all the time as examples, then sometimes there's a role for checking more nuanced thyroid markers like the direct level of the T3 and T4 in the body. Although those especially for T3, which is kind of there's less of it in the body than T4. And there's actually two forms of it. There's protein bound, which is like the total T3. And then there's free T3, which is the one that's kind of running around doing all the activity. Our labs are not really great at determining the true levels in the body. And so they're not so accurate, especially in terms of diagnosing hypothyroidism. Really only useful if someone has too much around.
Okay.
But the TSH will be able to clue people into to that.
Okay, so it's kind of the weighing these things against each other and making sure that you're just staying on top of it with your regular testing. You obviously want to establish baselines for people individually, and then you also
Mhm.
mentioned some of these things kind of naturally rise with age.
Yeah. And the TSH doesn't really change that quickly either. So if we checked the T3 or T4 directly, there can be more fluctuation, even like hour by hour to a patient, but the TSH typically changes much more slowly. So, if you had it checked a month ago, it's probably not going to be all that different from where it was now from where it was a month ago. If you check in a year, yes, it certainly can be 3 months. Certainly we can see it 6 weeks, probably. But it's not the type of thing that we check as frequently as a fasting glucose or as a troponin for heart attack or something like that.
Okay. So kind of following in this like in this line, right? You had mentioned that some of the testing isn't the best all the time, or at least alluded to it a little bit. Um, and so some people might come in asking for more like complex testing, and uh, internet culture is like a really big deal. Everybody's, get more biomarkers, get more testing, get all these things. And personally, I have a problem with it, mostly because not all testing is actionable, right? And most people have no idea what they're looking at, which ultimately just induces fear-based decision making, which is never good. But I have some notes here, so please forgive me if I sound ridiculous. But what about people who come in asking for like full thyroid panels or reverse T3 panels or things like that? Um, you're smiling a little bit, so I assume this is very silly to you. But um, if these are the things that people are coming in with, knowing that they likely heard it somewhere from someone and don't actually know what it is, how do you talk them through all of these additional testings? How do you talk them through your rationale for not ordering them initially or whatever the case is on a personal level? Because some people I know will feel like, well, why didn't you just give me all of the information in the beginning or whatever the case is? Does that make sense?
It does make sense, and that's something we actually deal a lot with from across the spectrum of lab testing and imaging testing. And you touched on really the key point here, which is if we are ordering a test on someone, whether it's a blood test, an imaging test, something like that. If we are ordering a test on someone, we have to make sure that we're ordering a test with where the result is going to change management and we actually know what to do with that result. We're not just getting it because we're curious, because that just leads to a black hole. That leads to a giant gray zone and we don't know what to do with it. So, with that in mind, there is a role rarely for things like reverse T3, which is an inactive form of the T3 hormone, where basically the molecule is just arranged differently. Um, in very rare cases of hyperthyroidism, specifically, the to get a little bit technical, some of the enzymes that are used in the body to convert T4 to T3 can go a little bit haywire, and you can get a ramp up of reverse T3. But that's a very rare scenario, and typically those tests are ordered under the guidance of an endocrinologist or someone who's like very knowledgeable in that space, and in someone in whom we have just really kind of time and time again proven that they have abnormal thyroid function, again through measurement of TSH T4. Um, so it is a conversation that is typically best done on like a one-to-one basis, and to be like, okay, if a patient is coming in with these concerns and they want these labs tested, why do they want these labs tested? What do they think that we can, or what are their expectations of how management would change based on the results that we're getting? And then typically a little bit of patient education and just shared decision making of, okay, here's what the studies that we point to, the best knowledge we have, point to on what should we order, and then how we alter management based on the results of testing. But I think with thyroid function in particular, that's something we see quite a bit more than in other areas of blood testing.
Yeah, I something that you touched on as it was almost a flyaway, but I think deserves more attention to what you just said. You talked a lot about how, well, a little bit rather, a little bit about how the conversation should be personal and it should be individualized. And, as a user of medicine and not a practicer of medicine, I think that is so, so important because there is a stigma online and in many circles of non practicing individuals, people spewing information online, talking about just generalized claims about medical professionals that I think is really, really awful. Um, Mainly because it talks about the concept of medicine as a whole, as though it is the way every single person practices. And I find it really interesting because it's, slow me down here, Doc. It sounds like you're advocating for having a relationship with your physician that is based on communication.
Absolutely. And to that point, like I personally, I don't mind when people come to me with an article or something, or even a TikTok video or something, right? Like, hey, I was told on this TikTok video that I should be ingesting cyanide on a daily basis, and please don't do that for anyone listening. But just as an example, right? That's a conversation worth having. And you know what it shows me is that the patient is engaged in their own health, that they're curious about bettering themselves. It's a positive thing. But you're right. It takes a lot more effort, and there's a term for this that I'm forgetting right now, but it takes a lot more effort to quash the BS and to like disprove the BS than it does to actually spew the BS. And so we're at a disadvantage a little bit here from the side of trying to quash some of the BS. But um, I honestly don't mind it when people come in being like, either skeptical of mainstream medicine or that kind of thing, because that's an opportunity to use the patient's passion about their own health and kind of just teach them about why, we do things a certain way. Are there bad actors in medicine? Of course, there's people who are better than others, and there's people who with malintent, sure. But I think as a whole, it's 99% of us are trying to do right by our patients. Um, and there's no, big conspiracy or big medicine kind of thing from the standpoint, especially of primary care physicians.
For
We just
sure.
simply don't have the time to make big, Dr. Evil-esque organizations. Uh,
Yeah, and I think that it's important to address that. And I love the fact that not just you, but all of our like our whole physician team is very, very humble in that way. In that, like, please bring the information you're getting, because the only way to combat bad information is with good information,
right,
right? If you dismiss every point that someone brings, even if it is ridiculous, the likelihood that they continue to bring things to you is very low. And
right,
so I love conversations like this because they feel very genuine. They feel very like whole. We're not skipping anything, and we're not trying to talk through anything. The intention is to simply talk through, like, what do we know for sure, and then address some of the things that we may have heard that are a bit more on the like, well, you can do that for sure, but it's usually unnecessary and likely merits an individual conversation, which isn't sexy information, but it is real.
right. That's
Uh,
exactly right.
well, that's awesome. So thanks for letting me go on that little rant and coming with me on it. I have more questions about thyroids.
Sure.
um, so I guess kind of pivoting back to what you were saying before. So we talked a little bit about kind of like extracurricular testing that doesn't necessarily get you anywhere. But let's kind of go to the other angle of this, where somebody's labs come back normal, but they still feel awful, right? They're coming back, and you listed a pretty wide array of symptoms that can be caused by, let's just call it a faulty thyroid, or if you want to correct me, please.
Hmm.
Um, but the labs are coming back normal. First of all, how do you approach that conversation? But then, I guess without getting overly specific, what do you do with that? Because that's a person who's, it sounds like they're a little bit at the end of their rope. They're kind of holding on, but they're looking for answers. What do you do?
That's a good question. Um, I think first and foremost, if someone, you kind of have to make sure that you're not anchoring on the thyroid being the issue in this case, and if the patient is anchoring on the thyroid being the issue, kind of double clicking on why, because it is possible to have a normal TSH, normal T4, and kind of there's a thing. It's pretty rare, and it's typically in the setting of illness, euthyroid sick syndrome, but it's typically not something a normal like a healthy person, unless they're like in the ICU or something like it, hospitalized, is going to come to you in the outpatient setting, and have an abnormal thyroid with a normal TSH. There are some instances, if you've ruled out certain autoimmune conditions like Hashimoto's thyroiditis, which is an autoimmune thyroid inflammation, where the initially it kind of burns out the thyroid hormone that's there, and then it goes into this phase of everything kind of looks normal, even though it's not, and then eventually you'll get to hypothyroidism. So that's possible. Usually pretty easy to rule out with a simple antibody test. Um, but again, as if you've, to the spirit of your question, if you've exhausted all of um, the workup to say, okay, is there actually something? Am I being fooled by the numbers here? And I don't think that I am. You have to start looking at other areas of organ systems, or either an organ system that's off, or something perhaps related to mental health, something perhaps related to an external stressor, or a toxin, or a substance, a medication even. um, to You kind of have to broaden your scope of what you look for, to say, okay, why is this person feeling so crummy? Um, and then what can I do about it and how can we fix that?
Is this an instance where you might advocate for like personal health data related to like a wearable or something along those lines? I know that those are they're non-medical devices, but in the instance where you're like, hey, this person's really hyper focused on the thyroid, um, it's it might not necessarily be the thyroid, but they still have symptoms that are in line with what we were discussing.
Hmm.
Um, I have to imagine that pulling data from somewhere else is effective for kind of moving them along this diagnostic track, right?
Yes, and I think probably first on the tier list of what I would, get would be additional blood work,
Mm,
just being a little bit more objective, and we know what to do with it a little bit more than wearable data, but it's still very useful, and I've got a wearable on right now. And that can help determine things like, are they sleeping well or not? Because that can certainly play a role into kind of non-specific symptoms. Some of the wearables will do activity tracking. Most will do activity tracking as well. So if a person was previously exercising a lot and now they're very sedentary, certainly that can contribute to feeling unwell. It can be there's a lot of different things that can make a difference there. As my webcam just flipped. But typically we'll start with the blood work, then wearable data can be useful, and also just kind of seeing if there's been any changes to their routine, to stressors, to diet, to their work, to travel, to illnesses, if they've recently started taking a new supplement that they were never previously on, or it could be really anything. And you really have to keep an open mind when the symptoms are very non-specific, especially when you initially considered thyroid dysfunction. Typically, you're considering non-specific symptoms.
mm,
Um, it's not
yeah.
like a rash where like, okay, that's can only be caused by a handful of things. This is like really these symptoms are very constitutional. They could be really anything. So keeping an open mind is useful, and wearable data can be useful. And we see it used a lot for actually most of the wearable data now is really useful in cardiology and diagnosing simple arrhythmias.
Hmm.
It can be really useful for that. But we're starting to see a lot more of it used in other ways. It's still very much the early stages of that, though. I think over time we'll see wearable data become a lot more useful than it currently is. And I'm really excited about that too.
Yeah, lifestyle data seems to be up and coming for sure. Obviously, the reliability of it is in question because it's not the most objective, right? And but it seems really interesting. And I mean, with something as broad stroke as thyroid dysfunction, it seems like something like that might be an interesting way to just find more points to maybe say like, your labs look good. Your lifestyle is a little crazy right now. Are there some external stressors, things like that? I know in personal training, that's a big factor with just movement science. You have somebody who's totally healthy. Um, they're able to do complex movement patterns. They're able to do overhead movement patterns. And they have a rough week or they're having a tough time with their family, financial stress, stuff happens that you don't always find out about. And suddenly their neck is all pinched up tight. And, suddenly you're looking at them like, oh man, they've got like the early stages of a movement disorder. And it's just like, what happened? Uh, and naturally, as any care provider, you want to just jump in and try to solve the problem. When usually that's not the best thing to do, right? Sometimes you need to understand the problem first. And I think that's just a nice callback to the sometimes more testing isn't always better,
Right.
especially if it's fringe testing, if you will.
That's
Um,
true.
but that's really interesting. So it's kind of like a full circle thing as far as movement science, as far as lab work. It's at the end of the day, you're problem solving. You're kind of taking in information and trying to utilize the most efficient sources of that data and
Right.
going from there, which is really cool.
Yeah. And the other
Uh,
piece of this is as well, not
Please.
to interrupt, but in terms if people are feeling unwell and they're already on thyroid hormone supplementation, adjusting the dose can be obviously very useful and important. Unfortunately, as I mentioned before, the TSH, which is what we use to guide treatment, does not change very rapidly, but it is easier than you'd think to give someone a wrong dose of thyroid hormone. Uh, and whether that's synthetic thyroid hormone like Synthroid or levothyroxine, which is probably the most widely prescribed option that we give patients who are hypothyroid, or a desiccated thyroid hormone, which is combination T4, T3, common brands of that are like NP thyroid and Armour thyroid. Um, but I've had patients who've come to me feeling really crummy, and uh, a simple review of their blood work shows that they're actually what we call iatrogenic hyperthyroidism, meaning someone is giving them way too much thyroid hormone and they're feeling really crummy.
Oh,
And
wow.
alternatively, people have come to me, and probably most primary care providers, on a suboptimal dose of thyroid hormone supplementation, and they feel really crummy because of that. And it takes a lot of the doses of thyroid hormone supplementation are on the order of micrograms, so 10 to the minus sixth power, which is crazy. It's tiny little amounts, right? But even small changes can make a really big difference. And so reevaluating, like just because someone is on thyroid hormone supplementation doesn't mean that A, it's the right dose, or B, they need to be on it forever. Um, and so reevaluating that in situations where patients are not feeling well is also really useful, not just assuming that what was previously prescribed to them or what they're coming to you with is correct.
That's really interesting. Without digging into this too aggressively or throwing anybody under the bus, but I think everybody who's going to hear this is going to be like, well, under what circumstance would somebody be overprescribed thyroid hormone and then also allowed to complain about how like poorly they feel, right? It's your reaction to that to me feels like, well, no, duh. You know, oh, you still feel terrible? Let's check if you're on too much, medication or the cases.
Mhm.
Um, the consumer in me demands justice here. Why might that happen? Especially if it's enough that you're like, man, I feel as bad or worse.
Right. And you certainly don't want to throw anyone under the bus because I wasn't there
Of course.
prescribing this in that situation. But ultimately, it stems from just a lack of understanding of basic thyroid physiology is really what it comes down to. Um, and people who reflexively see a number low and assume that means low function, where in fact it's the inverse. Or listening to a patient say they feel so crummy and just trying to overcome the patient's symptoms with medication and not looking at the numbers themselves just because you're kind of at a loss of what else could be causing it. You've ruled out everything else. You're like, ah, probably the thyroid. Let's try more hormone or something like
Wow.
that, right?
Okay.
So there are situations, and this is just me speculating as to the reasons why, but it's a shame because it's actually a very well established treatment protocol. It's a very well established steps that you take. The guidelines are very clear, and following the steps for diagnosis and management. While there is a little bit of nuance within the guidelines, staying within that framework, staying in that lane, really yields good results in virtually all patients.
So in this particular instance, you think that a person looking for another opinion, at least in this example, is appropriate just to get another set of eyes on it, and
Yeah,
it's not. It sounds like it's not so uncommon of a thing that people would be like, "Nah, that's ridiculous. That would never happen." Unfortunately.
right. Yeah, I've seen it this month, in fact. Yep.
Okay.
Yep.
Well, that's good to know, and I think it's worthwhile for people to be diligent and continue to advocate for themselves. But again, I mean, whether it's a double or a triple tap, I'll probably repeat this 100 times. You know, you got to find a physician who's willing to have real conversations with you, and it's one of my favorite things about you is none of these things uh, are off base. We're allowed to talk about these things. We're allowed to ask about these things. And me as a non-medical provider, I'm allowed to be ignorant about these things and ask silly questions.
Hmm. Yeah.
So,
And a lot of the time patients will bring things to me where I have no idea. I've never heard of this, what they're talking about. and I have to look it up or ask colleagues or things like that. And that's okay too, of course, as long as it's not like a very basic thing, right? But a lot of these questions are really good questions. But either A, we don't have enough data to really give a good informed opinion, or we just don't have the experience within that certain niche to give, an expert comment. So I think all of us here at Active Health try not to talk out of our rear ends when we don't know something. We'll actually find someone who does or a resource that does. But again, when patients come to us with those types of questions, it's very much a positive thing because it shows that they're engaged in their own health. They want to be an active participant in their own health and they want to improve themselves. And all those are very positive characteristics towards improving longevity, health span, and overall health.
Yeah, I love that personally. In the fitness world, the more questions you ask, the easier my job is. The more you allow me to educate you on how things work, how your body moves, why we might choose one protocol over another for a progression or a system
Mm,
for strength increases or whatever. The more you give me that room, the easier it is to
yeah.
accomplish the mission because context is so key.
And how often do you see that? I mean, kind of flipping the script here, like we talked about it within the medical visit, but someone coming to you for the first time, adamant that they're, I don't know, just a basic movement that they're squatting correctly, and you have to be like, well, actually, this is actually not optimal posture and movement and range of motion, kind of thing. And how do you approach changing, deep held beliefs, like that?
Yeah, that's a great question. I mean, for me, it always stems down to how a person moves is pretty individual, right? Biomechanics are kind of I don't want to call them fixed, but we know what's up, right? Elbows bend and they flex and extend, right? They're not going to start rotating at 180 degrees. They're not going to start doing weird stuff. We kind of know the deal. And so when it comes to the like subjective nature of like movement accuracy or correctness, um, an individual who has like long held beliefs, I will only challenge them when what they're doing is either dangerous or if it is kind of like, is the word hypocritical? Can you do the thing that you want to do well? If no, then maybe what you're doing isn't working and we should try something else. And it just makes me think again about the labs and everything like, well, let's just take a look and measure that against, are you feeling the way you want to feel? Can you move the way you want to move? Um, if you're like, I squat fine, but my knees hurt all of the time, and I assess a movement pattern and you just like your ankles are so rigid that you can't drive your knee over your toes, I'm not going to look much further than that because we're going to get down this deep dark rabbit hole of like theoretical, possible application when in reality we should just give you a little bit more range of motion at the ankle, which is probably pretty easy. So from that perspective, I don't want to say it's minimum effective dose or anything, but we want to tackle the thing that's in front of us that is the like largest and most clear barrier to entry. And I think that's really important because you want people to feel better or get what they're looking for as quickly and easily as possible because that's ultimately what buys you some of the authority, some of the trust to then continue to do that in the future when things do inevitably become more nuanced, right? As you get better, people are pretty straightforward, in my opinion. As you get better, possibilities for how much better you could do increase. And if you want to lose 50 pounds and then you do it, you're like, oh my God, I never thought I would lose 50 pounds. I wonder if I could lose 25 more pounds. Well, what you did to lose the first 50 is awesome, but it's probably going to be double the effort to get the next 25. You never would have accomplished the full 75 without getting the first 50 because you wouldn't have thought it was possible. And me coming at you with the information to kind of switch my points here, but for me coming at you with the information to lose 75 pounds, would be really intimidating, I think, and really, really deep cut. And so to stick with the squat concept, you know, maybe talking about the strength of your arch and like myofascial release and like blood flow patterns, like maybe none of that's necessary right now. I'm not hiding it from you, but I don't know if we're going to ever care
Right.
if the goal is to reduce the knee pain.
Hmm.
So I don't know. I see a lot of commonalities with the way we think about how to apply uh, not just like diagnostic tools, but also applying a solution for a person as well.
Right.
Um, if you don't mind, I wanted to hit on a quick panic one real quick.
Oh, sure.
A big scary one. Yeah.
Uh-oh.
People, lumps, bumps, and everything in between, right? Thyroid nodules, like
Yeah.
everybody is scared of the nodules.
Hmm.
Knowing you, knowing Dr. Nicole, knowing Dr. Abra, I know that this isn't always the scariest thing in the world, but people hear nodules and they think, I must have cancer.
Yeah. And that is something interestingly, so there's really three ways to diagnose thyroid nodules. One is that the patient comes to us and be like, I have a lump. And some people do, but that's pretty rare. And oftentimes the lumps are kind of higher up, like what we call lymphadenopathy, and that's in relationship to typically illness, sometimes rarely lymphoma, but usually like you had strep or you had an upper respiratory infection, you've got some lymph nodes that are reactive and they typically go away. So that's one, is the patient will come to you. Two is that we'll feel it on exam. So when we're doing this, like, talking to you during the exam, we're like, oh yeah, how's your, I don't know, cousin's husband doing or whatever, and feeling your neck. Where part of that involves feeling the thyroid, again, down here, lower down, to see if we feel a nodule, although typically they're quite small and can be difficult to feel on examination. And then the third way is we find it on imaging. Uh, Typically, it's actually not what we're looking for on imaging when we find it. They're often diagnosed incidentally, so you get a imaging test for some other reason, um, like a chest CT or something, just some other imaging test, and the radiologist says, "Oh, you've got some thyroid nodules. We should monitor those." An ultrasound is the easiest and best first way to evaluate nodules that are not. If your TSH is normal, we're assuming your TSH is normal here and you have normal thyroid function. We just do an ultrasound and we can score that. It's called a Thyroid score, where the radiologist will determine uh, if patients have a nodule, how big it is, how active it looks, and therefore if we need to do anything for uh, to biopsy it. And a biopsy is just a needle biopsy, which is like the radiologist or some endocrinologists can do this. They take a little needle and they stick it right in under ultrasound guidance. They get the nodule, boop, they take out a little sample and we can determine that if that is cancer or not. The vast majority of these are not cancer. Um, and it's not a screening that we do in healthy people with normal thyroids who have never had nodules. We don't typically screen for this just because they are very rare, and thyroid cancer is typically quite rare and treatable. Um, and so that's kind of where nodules come in. They're very, the guidelines on this are very clear. They're typically pretty easy to pick up on imaging and especially on ultrasound if we are concerned about nodules. And biopsy of these is very easy and the gold standard of telling you if you have something going on. And a lot of people do have nodules, and we monitor them over time. And then if they're benign for a long enough period of time, we sort of say, okay, it's just a benign nodule. You can forget about that.
Okay, so it's not necessarily you shouldn't panic about these sorts of things, is what you're saying.
That's right. Yeah. Thyroid nodules are not the type of nodule to panic over. Worst case scenario, it does end up being a cancer. There's a few different types of thyroid cancer, but most of them are actually quite treatable, which is good. So there's
I love that.
not a huge reason to panic. Obviously, they're like time is a factor, of course, um, but it's not, if you do get diagnosed with a nodule, incidentally say, it's just a reason to, let us know or let your primary care provider know, and it'll get addressed pretty easily.
Okay, well that's great.
Hmm.
I love how easy you made that. Nice and no need to worry about this. This is gonna be all right, and I appreciate that. We touched on this before, um, a little bit, but it's something that in my career I hear a lot about, mainly because of the type of training that we do, working with quite a few people who have like autoimmune disorders, and for whatever reason, this is super anecdotal, but it feels like there's a ton of autoimmune diseases related to the thyroid or in conjunction with it, or at very least, a lot of the autoimmune diseases that I seem to see or hear about are people with like Hashimoto's and like things like that. I don't want to say that it's common or anything like that. And again, who am I? This is completely anecdotal, just from like what I've noticed. But could you explain a little bit about like, some of the more common autoimmune diseases that affect the thyroid, and then speak a little bit about like what is Hashimoto's? How do you diagnose it? Why do I feel like everybody has it?
Hmm. So yeah, so you're actually not far off. It is a fairly common diagnosis in as far as I guess I should qualify that. It's not an uncommon diagnosis.
Okay.
The vast majority of thyroid abnormalities are what we call acquired hypothyroidism, which is just a run-of-the-mill low thyroid function for who knows what reason. But Hashimoto's is basically your body creates autoantibodies, so it attacks itself against a specific type of protein on the thyroid gland. And so there you can monitor for this very easily with thyroid peroxidase antibodies. And that's something that is just a simple blood test that you can do if your provider is concerned about this, or if you have a strong family history, or if the thyroid's kind of going up, down, and sideways. And
Mm.
if you recall from earlier, there is a spectrum of kind of clinical presentations of Hashimoto's, where initially when the autoantibodies are kind of attacking the thyroid gland and the thyroid tissue, a lot of thyroid hormone gets released just from just cellular destruction. And so that you can actually look hyperthyroid initially. Eventually, that kind of attack wears off, and then you enter the state of period of time, which can be quite a long period of time, where people are euthyroid. They have normal thyroid function because the destruction balances the normal tissue, I guess, and you have normal thyroid function. And then perhaps eventually the thyroid will become hypothyroid because you just don't have enough thyroid cells to produce the hormones that you need. And in those cases, we have to supplement with thyroid hormone. So that's the most certainly by far and away the most common autoimmune condition affecting the thyroid. There are of course others, but those are much 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 less common, and typically are the tests for those types of diseases are ordered in very rare clinical circumstances, and sometimes even a thyroid biopsy is done to help diagnose some of those other conditions. But Hashimoto is far and away the most common.
Sure, and it sounds like, um, for the lack of, I don't want to oversimplify, but it sounds like at the root of this, there's some kind of deviation at the thyroid, regardless of whether or not it's classified as an autoimmune disease or not. And it's going to be treated pretty similarly to if it were, classified as a hypothyroid or a hyperthyroid, whatever which way it swung.
Yeah, the management of this is generally very similar. There is maybe a little bit of nuance. Maybe we add steroids,
Yeah.
type of thing if
Inflammation
people
being a
are,
factor.
yeah, exactly, or to quell like the actual like autoimmune process
Okay.
to kind of shut down the immune system essentially and how it's overreactive. But the mainstay of treatment in thyroid dysfunction is normalizing the TSH. And so that is it. It's a very clear, well-defined goal. It's very objective. It's easily measurable by any lab. And so it's a very useful, again, like treatment for this is fairly, I mean, there's nuance to everything, but treatment for this is fairly straightforward typically.
That's great. Well,
Mhm.
that's good to know, and it's good to hear. Um, I guess let's close this thing out a little bit and talk a little bit, shamelessly about active health. Uh, if you're going to come be a patient of you or Dr. Abra or Dr. Nicole, how does our team approach changes with thyroid, compared to like an isolated visit, right? What's the team-based approach? What are we doing?
So great question. I think a lot of it goes back to what you had discussed before, where we have built into the practice a lot more time to have those one-on-one discussions with the provider where you'll be able to tell them your symptoms, tell us your symptoms, how you're feeling, and have that really nuanced discussion. So it's not an auto reflex of, oh, you're feeling unwell, thyroid test, and then you'll hear about it and see it in the patient portal, and there'll be a script waiting for you at the pharmacy, because probably, it's certainly not 100% that symptoms consistent with thyroid dysfunction are caused by thyroid dysfunction, frankly, and vice versa, right? Maybe there's a symptom that you think is caused by something else, but actually it's caused by thyroid dysfunction. And so being able to have actual nuanced conversations with your physician is really important. The other piece of this is really access, right? And so if you have a question on, I started taking thyroid supplementation and I have a question about how I'm feeling, or that type of thing, having the team members readily available to answer those questions in real time. Uh, and also, if, say, we're concerned about your thyroid, say we got a TSH for you and it was high, and we got an ultrasound and it was concerning, and we need you to get a biopsy, the team's following up and making sure you get that done. We're following up with an endocrinologist or a interventional radiologist to get the note from the procedure to be able to determine exactly what was done and what we need to do to help you follow up with that. So we're not just having you drift off into a system to navigate by yourself with a potential new diagnosis. We're essentially coaching you through that. And then we can also help you determine if you need to change your diet a certain way to help you feel better. If we need to change, it's pretty rare these days, but say we need to increase the amount of iodine that you're eating, which is a nutrient very closely related to thyroid function. We've got our health coach and dietitian who can help you and coach you exactly through that. Say we want you to build, you're finally now euthyroid, and we need to maximize you've been sleeping really crummy and you want to now get back into better sleeping habits. Our health coach can kind of walk through that with you. Say you've been kind of out of commission because exercise wise, say you've been living in the cold plunge that we have because you're feeling hot all the time, and now you wanted to try the sauna, or you wanted to try the gym now, to kind of maximize some of these other lifestyle factors that we talked about, which play huge roles in how patients feel. That is something where we have the dedicated staff in-house, and we can literally walk you from the exam room to the gym and talk with one of the trainers in 10 seconds, and have it all in-house right there. Everyone knows you, everyone knows about you. We can do that warm handoff. Um, and so that's a long-winded way of saying that we really just care and we give a crap, in a good way and in a structured way, so that we're not taking anything for granted, but B, making sure that we're following through with recommendations on how people can live healthier.
That's awesome. Great plug. Um, if let's end this really strong. If somebody's listening and they're worried about their thyroid right now, what's the first thing you want them to know before they get their labs done? Even before then, what's the first thing that you want them to consider?
Yeah, so if someone is worried about their thyroid function, say they're having these kind of non-specific symptoms, just always look to maximize some of the other lifestyle factors. Are you sleeping well? Are you eating well? And are you exercising? The big three, right? If you're not doing those three, do those. Um, if you come in and see us, well, obviously, it's very easy to check a TSH with reflex to T4. That is a very easy, inexpensive, quick lab test to have done. And so we can easily do that, but we need to be making sure that we're pulling all the other levers as well to make sure you're feeling well. So if you're concerned about the thyroid, just know that A, it's very easy to test. B, the guidelines are very well established. C, the vast majority of thyroid dysfunction conditions, whether high or low function, hyper or hypothyroidism, are exceptionally treatable, including most types of thyroid cancers, if and when it comes, not when, if it comes to that, which is again pretty rare. Um, so it is something that we have a lot of confidence in the health system across the board to help manage thyroid dysfunction. And then, of course, do your own, look up things yourself, come to the provider with information that you have, and make sure you're having those nuanced conversations, and staying as an active participant in your healthcare.
That was awesome. Well, that's it for us right now. That's all I've got for you. I think I've exhausted, at least the as much thyroid as I can think of. Um, but this was great. We're gonna do this every Wednesday, so you know, come ready. We're good to go.
I love it. Yeah, this was fun. It was a nice first kind of dive into this, and uh, look forward to continuing the conversation.
Yeah,
And everyone keep staying active.
that's right. Staying active. I love it. All right, thanks, John.
See ya.
Bye.